presentation will be nutritional management in ICU for patients with COVID-19. The screen is yours, Dr. Dina.
Good evening. My greetings to my colleagues everywhere, and special greetings to my colleagues in Qasr Al Aini Hospital. Today I will talk about the nutritional management in ICU for patients with COVID-19 infection, challenges and recommendations. The delivery of nutritional therapy to patients with COVID-19 disease should follow the principles of critical care recommended by and the Society of Critical Care Medicine. The delivery of nutrition in critically ill patients should take into consideration the following principles. Cluster care, meaning that all attempts are made to bundle care to limit exposure and to adhere to minimize droplet exposure and to utilize the personal protective equipment to protect healthcare providers. We can talk about the management of these patients as regards three periods: pre-intubation period, ventilated period, and post-mechanically ventilation period. We start with pre-intubation period. In COVID-19 patients who are not intubated, if they are not reaching energy target with an oral diet, oral nutritional supplement should be considered first. And
Dr. Dina, sorry, Dr. Dina, for interruption. We have okay, now.
I can't hear you.
There's no sound, Dr. Dina.
What? Sorry?
There's no sound, Dr. Dina.
Elevate the sound?
Okay, no, it's fine now. You can go on.
Okay, thank you. So in the pre-intubation period in COVID-19 patients who are not intubated, and if they are not reaching the energy target with an oral diet, oral nutritional supplements should be considered first, and then enteral nutrition should be considered. If oral intake is not possible, early enteral nutrition within 48 hours in critically ill patients should be initiated rather than delaying enteral nutrition, and this is the recommendation of the European Society of Enteral and Parenteral Nutrition. And this also recommendation, early enteral nutrition, is recommended by the American Society, the ASPEN, who recommends initiating early enteral nutrition within 24 to 36 hours of admission to the ICU or within 12 hours of intubation and placement on mechanical ventilation. What's the rationale behind early enteral nutrition benefit? It's initiating early enteral nutrition reduces mortality and infection rate compared to delayed enteral nutrition. We are still in the pre-intubation period, and in this population not reaching energy protein target by oral or enteral nutrition, it is advised to prescribe here parenteral nutrition. And if the patient doesn't have a central line, we can give peripheral parenteral nutrition. We call this parenteral nutrition supplementary parenteral nutrition. Still in the pre-intubation period, if the patient is receiving non-invasive ventilation, the recommendation is to start enteral feeding in these patients could be impaired by the fact that placement of a nasogastric tube may result in air leakage that may compromise the effectiveness of non-invasive ventilation and cause contamination with the virus. Also stomach dilatation that may affect diaphragmatic function and affect non-invasive effectiveness. So peripheral parenteral nutrition here might be considered. Now, if this patient is intubated and receives ventilation, mechanical ventilation, here the recommendation of the European Society is that intubated and ventilated ICU patients should receive enteral nutrition started through nasogastric tube. And the gastric route here is preferred as it requires minimal expertise and facilitates earlier initiation of feeding. Ideally, in patients with gastric intolerance after prokinetic treatment, and if gastric residual volume is more than 500 milliliters, post-pyloric feeding can be started. And here the ASPEN recommends that if you start post-pyloric feeding, duodenal tube should be inserted quickly. However, regarding the duodenal tube placement, placement of post-pyloric feeding tubes may take longer time to be placed than gastric tubes, increasing the exposure time of the healthcare practitioner. And placement of any enteral access device actually may provoke coughing and should be considered an aerosol generating procedures. This has to be considered. Also, if the decision is to put a post-pyloric feeding tube, confirmatory abdominal X-ray should be clustered with chest X-ray timing. As regard prokinetic agents, we said that the second step after trial of enteral feeding is to give a prokinetic agent to improve the gastric tolerance for feeding tolerance. However, we have to it is suggested in this prokinetic agent suggested to be used in COVID patients if needed. These prokinetic agents strongly considered when feeding in prone position. However, it should be noted that hydroxychloroquine, which is used sometimes in COVID patients in some countries, can interact with metoclopramide and erythromycin, and has the potential to cause cardiac arrhythmias like torsade de pointes and prolonged QT intervals. So this should be considered. Regarding the gastric residual volume measurement, according to the ASPEN American Society, checking for gastric residual volume in this patient population is not preferred due to exposure concerns and interruption of enteral nutrition delivery. However, monitoring of signs and symptoms as abdominal distension, vomiting, bowel movements, flatus, are bedside techniques that has to be done by nurses and physicians during their physical assessment. Continuous rather than bolus enteral feeding here is strongly recommended, and it's recommended because it decreases exposure of healthcare team to COVID patients. Also, it causes significant reduction in diarrhea with continuous enteral feeding. When to delay enteral feeding in these patients, like any other critically ill patients, enteral nutrition should be delayed in the presence of uncontrolled shock, unmet hemodynamic and tissue perfusion goals, in case of uncontrolled life-threatening hypoxemia, hypercapnia, or acidosis. Low-dose enteral nutrition can be started again as soon as shock is controlled with fluids, vasopressors, or inotropes, while remaining vigilant for any signs of intestinal ischemia. Early parenteral nutrition should be initiated as soon as possible in high-risk patients for whom early gastric enteral nutrition is not feasible. And in COVID-19 patients, the threshold for switching to parenteral nutrition may need to be lower. What about energy target? When patients are stabilized and even in prone position, enteral nutrition can be started ideally after measuring indirect calorimetry. And this is the best, of course, for measuring energy requirements. However, alternatively, CO2 production derived from ventilator will give a better evaluation of energy expenditure than predictive equations if indirect calorimetry is not used. And we target to start with 25 to 30% of the measured energy expenditure, and energy administration then increases progressively. According to the ASPEN, during emergency times, the predictive equation recommending 20 calorie per kg per day can be used, and energy should be started with 25% increased to 50 to 70% at day 2 to 3, and then at day 4 it reached 80%. According to the ASPEN here, Feeding should be initiated with low-dose enteral nutrition. Here, the same as mentioned by the ASPEN, hypocaloric or trophic, advancing to full-dose enteral nutrition slowly over the first week of critical illness to meet energy goal of 15 to 20 calorie actual body weight. And this is the same recommendation of the ASPEN, which could be around 70% of the caloric requirements, and protein goal of 1.2 to 2 gram per kilogram actual body weight per day. These are the ASPEN recommendation. While energy requirements can ideally, as we said, determined by indirect calorimetry, the principle of clustering of care is particularly important, and instead it might be advisable to use weight-based equations to estimate energy requirements as a practical matter for the COVID-19 patients, and also the carbon dioxide consumption as stated by the ASPEN. And why we go gradually on giving calories, this is because there is a progressive early, we go with a progressive early enteral nutrition. We start slowly increasing enteral nutrition provision because there is an endogenous production of energy inside the body in the first 3 days of illness. And if we are going to increase the enteral nutrition or to start parenteral nutrition, we can start after this endogenous production goes down. There's also studies pointing that the best outcome of substrate supply at this critical time, acute time, is 70% of the measured energy expenditure, as you can see by Zussman et al. And also here, the best survival was with 70% of the target. The worst survival was 30% of the target, and in between was the 130% of the target. So this is an illustration of how we should go gradual on calories and protein. In the acute phase, from day 1 to day 4, we start at day 1 with 25%, we go to 50 and then to 70 or 75. By day 4, in the post-acute stage, we can increase more than 70, and in the post-ICU phase, we can increase more, and in the post-hospital discharge phase even, that my colleague Dr. Amr will talk to you about, we can increase more. We have to be aware of refeeding syndrome because critically ill patients with COVID-19 disease have been reported to be older with multiple comorbidities, and such patients are often at risk of what's called refeeding syndrome. And the first 3 days are the period of highest risk. As you can see, the refeeding syndrome is due to after starvation, due to reintroduction of food, particularly carbohydrates, and with glucose uptake, there is sudden drop of hypokalemia, hypomagnesemia, hypophosphatemia occurs, and thiamine deficiency with salt and water retention and generalized edema. That's why it's recommended by both the European Society and by Manelli 2020 to follow serum phosphate, magnesium, and potassium levels closely for the high possibility of refeeding syndrome. What about protein requirements? During critical illness, the ASPEN recommendation are to give 1.3 gram per kg per day, actual body weight per day. And also in protein, we should reach the target by day 3 to 5. For persons with obesity, we give also 1.3 gram per kg per day, but we use the adjusted body weight. What's the role of timing of protein intake in these patients? We said to reach the target by day 5, 3 to 5. That's because a gradual increase study by Christine et al. In 2019 showed that gradual increase from low protein intake in the first 2 days to intermediate on day 3 to 5 to high protein intake from day 6 is associated with a lower 6 months mortality. And in addition, the overall low protein intake is associated with the highest mortality in the ICU and in hospital. As you can see, this is the illustration. The best outcome was the green line with a patient who started with less than 0.8 gram per kg per day during day 1 to 3 and increased to more than 0.8 gram per kg per day during day 4 to 7. And the worst actually were these patients with less than 0.8 gram per kg per day all through the ICU stay. So why are protein important during critical illness? Because the catabolic response leads to reduction in muscle mass to up to 1 kilogram per day during the first 10 days of ICU stay in patients with multi-organ failure. What about nutrition therapy during ECMO? ECMO sometimes is used in these patients, and the recommendation of the aspirin is to start early low dose of trophic enteral nutrition in those with, on ECMO with close monitoring of the feeding intolerance and slow advancement to goal over the first week of critical illness. The largest observation study of enteral nutrition during veno-arterial ECMO found that early enteral nutrition as compared to delayed enteral nutrition in these patients was associated with improvement in 28-day mortality and 0 incidence of bowel ischemia. Now the patient is extubated and in the post-mechanical ventilation period. What are his problems? Actually, we face what's called post-extubation dysphagia. The post-extubation swallowing disorder could be prolonged for up to 21 days, mainly in the elderly and after prolonged intubation. The presence of severe post-extubation dysphagia was associated with pneumonia, re-intubation, and hospital mortality. In ICU patients with dysphagia, texture-adapted food can be considered after extubation, and if swallowing is proven unsafe, enteral nutrition should be administered, started again. How much is the nutritional intake post-ICU? In post-ICU patients, a recent study reported an average spontaneous oral calorie intake after extubation of 700 calories per day only. The entire population studied consumed less than 50% of calorie and protein needs of post-ICU stay period. Recent unpublished data suggest that after removing the NGT from post-ICU patients on the general ward, the intake of calories drops by 22% and protein intake by 27% of target. So in a paper by Van Zanten et al., he indicated that these data suggest that prolonged tube feeding until oral nutrition intake is sufficient should be considered as an alternative to usual care. Finally, after extubation and discharge to the ward, we face also another problem that's called ICU acquired weakness. And that's the loss of skeletal muscle mass and muscle function that may be tremendous and a major problem in ICU survivors. Prolonged reported duration of ICU stay above 2 weeks for many COVID patients further enhance muscle catabolic conditions. Appropriate energy delivery and adequate protein administration are crucial for prevention of this severe loss of muscle mass and function. Recent evidence seems to indicate also the potential positive impact of physical activity for these patients for prevention of muscle loss. Finally, to summarize the points, important points of this lecture, actually, to take home message, The European Society have put a statement here and a conclusion that if you have a patient outside the ICU, you have to check for malnutrition, optimize nutritional status, encourage physical activity, and if there is a malnutrition, supplement with food, vitamins, and minerals, give oral nutritional supplement, give enteral nutrition. And for ICU patients, after, of course, assessment, I'm checking for malnutrition. If in non-intubated patients, if energy target is not reached, with an oral diet, oral nutritional supplements should be considered first, then enteral nutrition treatment. In intubated patient, enteral nutrition should be started through a nasogastric tube and post-pyloric feeding. If performed, you should try prokinetic agents first, and it carries the high risk of exposure. In intubated patients who do not tolerate full dose of enteral nutrition during the first week of ICU, initiating parenteral nutrition should be weighed on case-to-case basis, and in general, the threshold for initiating parenteral nutrition in these patients is low. In patients with dysphagia, texture-adapted food can be considered after extubation. If swallowing is proven unsafe, enteral nutrition should be administered. Thank you very much.
Thanks a lot, Dr. Dina, for your elegant presentation and informative as well. Okay, now I will present myself. Now let's move to my presentation. My presentation.
Yes. Ladies and gentlemen, I'm so pleased to introduce Professor Amr Abdulmunam. Professor Amr Abdulmunam is